So I've been tasked to explain neurovascular dysregulation in 20 minutes in MECFS and some of the insights we've gained from invasive exercise testing. And a lot of this work was when I was a fellow at Brigham and Women's Hospital. My first rotation was in the exercise lab with Dr. Systrom. And I remember the first case I saw of this, which was of preload failure. And Dr. Systrom said to me, "This is a classic case of preload failure." This is in 2015. I was a new fellow in the Harvard system, and I thought, oh man, I really don't know anything. So I spent all night looking this up, preload failure, PubMed, Google, couldn't find anything. And I went in the next day and I said, "Dr. Systrom, I couldn't find anything here." And he said, "That's right, you're gonna publish on this." So I don't have any disclosures. I remain an academic physician. So the goals to discuss the use of the invasive CPAP in the evaluation of unexplained dyspnea, explain the pathophysiology of exertional intolerance in MECFS, describe exercise phenotypes in MECFS, and describe the use of pyridostigmine to treat neurovascular dysregulation and potentially explain some of the underlying pathophysiology. A lot of this is repetition from yesterday as well. So I would say that initial conversation with Dr. Systrom inspired me to go back to the basics and textbooks. This is Dr. Singh and I in my apartment. Fellows in the Harvard medical system have to read physiology textbooks at night to each other. And that is me pretending to read upside down. Shows you how much I know. But I think it's worthwhile going back to the basics and the Wasserman diagram, which is really a simplistic way, but also it gives us a good way to think about approaching dyspnea and approaching, is there a pointer here? Okay. How oxygen is being absorbed or being oxygen uptake from the atmosphere through the ventilatory system, through the left side of the heart, delivered to the muscle bed, and used by the mitochondria to produce ATP. That's what it's all about, producing ATP. And then carbon dioxide production going through the venous system, through the right side of the heart, and being exhaled into the atmosphere. Any break in these gears can cause dyspnea, can cause exercise intolerance. So this is where the invasive exercise test comes into place, which is we can have a very complete look at all those facets of exertional intolerance by using a Swan-Ganz catheter. This is, again, Indy Singh in my apartment playing with the catheter. So this is meant to illustrate that this is a it's a minimally invasive tool that has minimal complications done with experienced hands and is used to expand upon the differential that I'll go into in the next slide. This is just a video of the invasive exercise test that we've set up at Yale. Oh, I know there's sound here. I don't know if you can mute the sound, but Dr. Systrom showed a similar video yesterday. So there's a continuous measurement of intracardiac pressures throughout exercise.
A wedge, please.
Every minute, we're calling for a wedge pressures, which is a surrogate for a left atrial pressure, a left ventricular, and diastolic pressure. Every minute of exercise, there's a mixed venous sat and an arterial sat being drawn to calculate a direct thick cardiac output. We push patients to the max, so you could see a patient going through maximal exercise, and then see the thumbs up, so that just reinforces that Dr. Systrom was correct, that patients do say that this is better than a dentist's office. And the whole point is to expand upon why someone has depressed or decreased aerobic capacity, as defined by a VO2 less than 80% of predicted. We look for pulmonary mechanical limitations to exercise, which is a non-invasive assessment. And then we're further refining this algorithm with looking for central cardiac limitations to exercise, looking for left heart disease, which is important. It's not letting up. So left heart disease, especially in the long COVID group, pulmonary vascular disease, and then preload failure. And this combination of preload failure and the peripheral limitation, which is impaired systemic oxygen extraction, is commonly observed in ME/CFS. And I'm going to hopefully prove that to you in the next few slides. So we're going to hone in on the circulatory gear here. These data have been presented throughout this conference. So this started this is years before I started fellowship. Will Oldham and David Systrom published this paper looking at patients with unexplained dyspnea who presented to the invasive CPET lab, and after ruling out significant cardiopulmonary disease, exercise pulmonary hypertension, exercise pulmonary venous hypertension, and looking at patients who had impaired VO2 and normal VO2. And in the impaired group, it's just showing that they had an impaired VO2 of about 53% of predicted. They had a decreased cardiac output, and this was a function of preload failure. So they had an inability to augment their right atrial pressures and their wedge pressure. Sorry, here it is. So right atrial pressures remained low at peak exercise. Wedge pressures also were on the low side. So the summary from this is that preload failure may contribute to exertional intolerance in a subset of patients with unexplained dyspnea. Further review of some of the records of these patients with impaired oxygen uptake and preload failure showed that there was a hint towards dysautonomia, or disorders of the autonomic nervous system. Some of them had abnormal tilt table tests, abnormal nerve conduction studies, abnormal tests of adrenal function. And around this time, there was increasing evidence of small fiber neuropathy, used to be called small fiber polyneuropathy, that may underlying commonly associated disorders such as fibromyalgia, such as widespread pain syndromes, and POTS, postural orthostatic tachycardia syndrome. So we decided to look at this and assess if small fiber neuropathy was prevalent in ME/CFS in our invasive CPET cohort. So this is the famous Phillip Joseph paper that's been thrown out throughout this conference. So this is a paper we published in Chest about our insights from invasive cardiopulmonary exercise testing in ME/CFS. So same kind of algorithm, which was we looked at our total invasive CPET database, took out the patients with missing data, significant cardiopulmonary disease such as exercise pulmonary arterial or venous hypertension, and honed in on the patients with low right atrial pressures, a right atrial pressure below 6.5 millimeters of mercury. Then we looked at patients who had the presence of a skin biopsy and did a chart review or a telephone questionnaire to see if they had a diagnosis of ME/CFS based on the National Academy of Medicine criteria. So out of the 1,500 or so invasive CPETs, we had a study cohort of 160 patients with ME/CFS and the presence of a skin biopsy. This is just baseline characteristics showing that at least in the United States, in Boston, it was a middle-aged female population. BMI was normalish for an American, 25. Very different in Europe. And the take-home message here is that, sorry, the pointer is not pointing out there, but there was a high prevalence of small fiber neuropathy, around 31%, defined as a neurite density below the 5th centile, and similar to the prevalence in POTS and in fibromyalgia. Unfortunately, neurite density did not correlate or was not associated with physiologic parameters such as VO2, cardiac output, and right atrial pressures. This might be a limitation in our technique. at least when I was a fellow, the skin biopsies were at one site over the the medial malleolus, and it's small fiber neuropathy is a patchy disease, so we might be underrepresenting the presence or the prevalence of small fiber neuropathy. Not sure if I would just say there's no correlation thus far, but maybe that should be something to be investigated. So, interim summary number 2, small fiber neuropathy may be the underlying pathophysiology of preload failure and ME/CFS. In addition, we also decided to look at this last skier that's often forgotten, the muscle bed and mitochondrial function, or how oxygen produces ATP. So buried in the one of the tables in that original preload paper is that in the impaired group, there was a signal towards impaired oxygen extraction or systemic oxygen extraction. The oxygen extraction should approximate the hemoglobin at peak exercise. So if we assume a hemoglobin is normally at 12 to 14, it being a 10 is a little bit low. Dr. Systrom showed this. This is from our original paper in CHEST. So what we decided to do was look at tertiles of flow in our cohort of 160 ME/CFS patients, and showed that there was a low flow group and a high flow group. And in that high flow group, there was evidence of impaired systemic oxygen extraction. I think numbers illustrated as well. So in that high flow group, the mixed venous sat at peak exercise, so high flow, and then the second row, highlighted row there, mixed venous sat at peak exercise was 45%. Normal mixed venous sat in the deconditioned individual, after some studies, and elegant studies in the 80s, is around 25 to 30% at peak exercise. So 45% represents a massive inability to absorb oxygen and convert that to ATP. Potential reasons for that could include peripheral left to right shunts. Someone rightfully asks, could there be a presence of an intracardiac shunt? We always do an oximetric shunt run during the resting right heart catheterization to rule that out. So the differential is peripheral left to right shunts or mitochondrial dysfunction. This is a paper looking at palmar biopsies in patients with fibromyalgia, showing that there was abnormal innervation of cutaneous AV shunts, potentially explaining this peripheral left to right shunt hypothesis, or supporting it. So in these patients with fibromyalgia, they had an increased area of peripheral or cutaneous AV shunts. The black is the fibromyalgia patients. And it was, there was evidence of more vasodilation of these shunts. So neuropeptide Y is a vasoconstrictor. CGRP is a vasodilator. So when that ratio is lower, that means you have more CGRP, more vasodilation. So more vasodilation of those cutaneous shunts. So again, reinforcing peripheral left to right shunts. So third interim summary, there are high and low flow phenotypes of ME/CFS. The high flow phenotype may be caused by peripheral left to right shunts or mitochondrial dysfunction. And the overall theme here is that this is potentially due to dysautonomia, causing left to right shunts, and then dysautonomia in terms of the preload failure, causing impaired venoconstriction and impaired venous return to the heart, which the last few slides will hopefully reinforce. So I know there are a lot of patients here. When I sit and stare at a patient, I'm not just giving silence. I am thinking about what I can do. But in all seriousness, I do understand that in ME/CFS patients, we don't have much that we can offer. And hopefully this will give some hope about some next steps. So this was Dr. Raj, who has published some great work in POTS. We got this idea of using pyridostigmine from this paper, which was using a single dose of pyridostigmine, 30 milligrams. And what this showed was that there was improved heart rate recovery during a tilt table test and symptom burden. The mechanism behind this is that is cholinergic sympathetic stimulation. So acetylcholine at the ganglion is broken down by acetylcholinesterase. Proteostigmine is an acetylcholinesterase inhibitor. So there's more acetylcholine and more norepinephrine released at the postganglion, leading to improved blood pressure. We use a similar concept. So this was our latest research study published in CHEST as well. Neurovascular dysregulation and acute exercise intolerance in ME/CFS. And what we did was we used invasive CPET to both see if we can provide a mechanism for treatment and explore underlying pathophysiology. So patients with ME/CFS who were undergoing a clinically indicated invasive CPET would be randomized. This was a double-blind randomized clinical trial to either getting pyridostigmine, 60 milligrams, or placebo. They would have a rest period of about 50 minutes, and then they would re-exercise using invasive CPET. And we would gather hemodynamic data and gas exchange. And this was a positive study. Small signal, I will admit that. But what we showed was that there was a positive treatment effect in terms of peak VO2. So VO2 improved after use of pyridostigmine. And this was by mechanism or by nature of improved cardiac output and improved right atrial pressure. So the theory is that there was improved venoconstriction, improved venous return, causing an increase in cardiac output and VO2. I think the other use or utility of this study was that it was exploring underlying pathophysiology. And if you notice in the placebo group, VO2 decreased. Peak to rest cardiac output also decreased by -2, and right atrial pressures decreased as well. And could this be potentially explaining post-exertional malaise after exercise? This is a cartoon that we came up with, similar to the cartoon from the Potts paper. So again, reinforcing that pyridostigmine acts at the ganglion here, reducing the breakdown of acetylcholine, and then postganglionic release of norepinephrine, causing venoconstriction, improved venous return to the right heart, improving right atrial pressures, and cardiac output and VO2. So in summary, I hope I proved to you that ME/CFS is real and that there's physiology or pathophysiology that can be explained by invasive exercise testing. That preload failure contributes to dyspnea. That small fiber neuropathy may be the underlying pathophysiology of preload failure due to impaired venoconstriction. That small fiber neuropathy can contribute to the high flow phenotype of ME/CFS by causing peripheral left to right shunts. And that pyridostigmine may improve aerobic capacity by increasing cardiac output and right ventricular filling pressures. I think one limitation there is that, and I think appropriate that Dr. Sisham put the LIFT trial at the end of his slide, is that we don't have any long-term data about pyridostigmine's utility in this disorder. So it'll be exciting to see what LIFT comes up with. And then I don't think I'm taking questions right now, but those are my cats because I don't have kids.